Hello, everyone. Sorry, we were having a little technical difficulty, but Dr. Sims fixed it for us. So you're gonna have to tell me later how you did that. So thank you all for coming. We're gonna let everybody come into the webinar room here. So while everyone's joining, I wanted to start off by introducing myself. My name is Amy Onder, and I'm the president and CEO of the Lupus Foundation of America Heartland Chapter. The Heartland Chapter is located in St. Louis, Missouri, and we cover the state of Missouri, Kansas, and southern and central Illinois. And tonight's webinar is a joint effort between some of the Lupus Foundation chapters across the country. And we pick different topics and speakers and offer our Let's Talk About It program several times throughout the year. So we're glad you're here. If you are just joining us, if you want to drop us a note in the chat and tell us where you're joining us from, it'd be great to find out from where everyone's joining. And I also wanted to remind you that if you have any questions after tonight, you can certainly get in touch with the Heartland chapter or your own local chapter. And we are happy to answer any questions you might have, or if you have questions about upcoming programs or support groups in your local area, please make sure you reach out to your local chapter. I want to remind you that tonight our speaker is providing information. She doesn't know you particularly or know about your specific kind of lupus. So it is really important for you to not ask specific questions, because she won't be able to answer those. And I also want to mention that she is going to do a presentation, and then she will answer your questions. So please just drop your questions in the Q&A section or in the chat, whichever one you want, and she can go ahead and answer your questions when she's done with her presentation. I also want to just mention that Dr. Sims has presented with us before, and it was such an excellent presentation that I wanted her to come back for a larger group. So you guys are really in for a great, informative presentation on a topic that I personally think is extremely important for people who are living with lupus. So we're going to go ahead and get started. So again, hold your questions until the end. And so I'm happy to introduce Dr. Catherine Sims. She's a rheumatologist at Duke University, working under the mentorship of reproductive rheumatologist, Dr. Megan Klaus. Her research initiatives include quantitative and qualitative pregnancy outcomes in systemic vasculitis, the creation of a pregnancy planning scoring system for women with SLE, the utility of serum biomarkers to differentiate between preeclampsia and episodes of lupus nephritis during pregnancy. Working closely with national advocacy groups and patient representatives, she has created patient-centered, easily accessible information detailing the importance of birth control, intentional pregnancy, and family planning for people with vasculitis. Through novel research efforts, education of providers, and streamlined communication with patients, her hope is to improve the reproductive experience for women with with autoimmune diseases. So thank you so much for joining us, and I will turn it over to you, Dr. Sims.
Thank you, Amy. And somebody had mentioned that the chat is disabled. I tried to enable it so people can put in questions. Oh, there we go. Looks like it's working. Okay, perfect. Yeah. Okay, I'm going to go ahead and share my screen. Thank you, Amy, for that introduction. And just let me know if there's any issues if you guys can't see my slides or hear me very well. So my name is Catherine. I'm down here in Durham, North Carolina, and this is my favorite talk to give, because my goal here tonight is to encourage you all to create family planning goals for yourself, and then work really closely with your rheumatologist and your other physicians in order to achieve those goals. So I find that some women are a little hesitant to come to these talks because they're afraid that I'm going to tell them, don't get pregnant. We don't want you to do this. Some of my patients have said, oh, I just showed up pregnant because nobody would help me, and this is what I wanted, so I just did it. And we want to give you a plan so that you have the safest pregnancy possible. Or not have a pregnancy. We'll talk about birth control as well. So I am not here to discourage you. I am here to inform you and help you to make the best decisions for yourself and for your future pregnancy, if that's something that you're interested in. All right. So this is an overview of all the topics that I'm going to talk about. So we're going to start off with birth control. And there's different types of options. There's pills and IUDs. So we'll go through each of those and which ones are safe depending on your lupus and maybe some of the serum biomarkers or autoantibodies that you have. We'll also talk about what happens when birth control fails and what your options are there. What if you want to get pregnant? And a lot of times I get the question, when should I get pregnant? Is my baby going to be healthy? What medications are safe to take? So we'll walk through all the important aspects of pregnancy planning and the pregnancy itself. And we'll talk about which doctors should be involved, what medications you should be taking. And then we'll move on to breastfeeding. And typically a lot of the rules that we apply in pregnancy overflow into breastfeeding as well. So it's not like you have a whole different set of rules in breastfeeding. They're pretty similar. Next is, what if I get pregnant when I wasn't planning on it? What are my options? Infertility is a big question that we get asked about in ART or artificial reproductive technology. So we'll talk about some of the options for women with lupus if you do encounter infertility. Menopause. And lastly, I always have a little section for COVID vaccinations because especially women who want to get pregnant or women who are pregnant are having a lot of really great questions about the safety and efficacy of COVID vaccinations. So I always have a few slides on that as well. All right, so just like I said at the beginning, I'm here to empower you because women with lupus shouldn't have their personal goals limited because they have a chronic illness. So we don't see lupus as something that should limit your life. It's something that you have to deal with on a daily basis, but you still have the same goals as women who don't have lupus. And so we're here to help you move those goals forward and get the best information possible so that you feel comfortable with the decisions that you're making about your own body. So I'm going to talk a lot about this handout, and this can be found on lupuspregnancy.org. It is a two-sided handout, and the first side talks about birth control and pregnancy prevention, and the other side talks about pregnancy planning. I typically tell women that if you're interested in becoming pregnant in the next year, then we're going to be talking about the pregnancy planning side. But if you do not want to become pregnant in the next year, then we're talking more about the birth control side. But we're going to go through both today. But if you want to reference it later or print it out, there's a PDF version on lupuspregnancy.org. And what we encourage women to do is to read it over, take notes on it. And you can also bring it to your doctor's appointments. And we want you to bring it to all your doctor's appointments, not just with your rheumatologist, but if you have a kidney doctor or a hematologist, or even to your gynecology appointment. It's really helpful for them to see what our thoughts are. And we'll talk a little bit about how sometimes doctors have issues communicating with each other, and then the patient gets kind of stuck in the middle and has to advocate for herself. And we really want to prevent that, because it puts patients kind of in an awkward position, and then nothing really gets done because all the doctors are kind of deferring to each other. So we see this handout as a way for you to advocate for yourself and come up with a birth control plan or a pregnancy plan, depending on what your goals are. All right, so let's talk about birth control first. My mantra is that if you are sexually active, you need to be on birth control. You need to have some type of birth control plan. Not every woman is going to agree on the same birth control. So one woman may prefer the subdermal implant. Some women may say, I want an IUD, but some women are like, listen, I don't want any foreign objects in me, so I would rather do the pill. So there's a lot of different options, but at least know how effective the birth control is that you're taking. So there's different tiers of birth control, and I'm gonna go through the 3 different tiers, and it starts with most effective and goes down to least effective. When you're picking a birth control, 2 things that you need to keep in mind are how active is my lupus, and do I have a history of blood clots, or am I high risk for blood clots? And that looks different for every woman. So some women's active lupus looks like a lot of hair loss or oral or nasal ulcers, or they have a rash. Some women have kidney involvement or lung or heart involvement. So the way that you find out how active your lupus is, I'm sure you can feel it in your own body, but then you also go to your rheumatologist and they do a full exam, they'll get blood work, they'll get a urine sample, and they'll be able to talk through with you how active your lupus is on a global scale. So you want to know how active you are. And then you also want to know, do you have certain antibodies that make you higher risk for clotting? And these, there's 3 autoantibodies, and they all have super long names. And I don't expect you to remember them, but they're on that handout on lupuspregnancy.org. So there's 3 of them. And some women are positive for one, some women are positive for all three. And your risk of clotting depends on how many are positive and how high they are, like how positive the autoantibodies are. It's kind of on a scale of maybe in the 20s up into the 100s. So it's not something that you're going to know about yourself at baseline. You need to talk to your doctor about these autoantibodies and about the results. And that also will be really important for both fertility treatment and also for pregnancy. And I'll talk about that a little bit later. Some women who are spilling a lot of protein into their urine, which indicates kidney inflammation, sometimes you spill so much protein that you actually have an increased risk for blood clots because you lose certain proteins that help prevent blood clots. And that's not something that's very intuitive, but if you're spilling more than 3 grams of protein at one time, then you're at higher risk for blood clots. And when your doctors get that urine sample at your appointment, that's what they're looking for. They're looking to see, are you spilling any protein? And if you are, how much protein? So it's important to know all these different factors because some birth control can make you higher risk of clotting. And you've probably heard this before. So women who smoke or women who go on long airplane rides, those types of things make you higher risk if you're on an estrogen containing birth control. So depending on these different factors, about your type of lupus, how active your lupus is, what antibodies you have to pick a certain birth control that's right for you. So what are those? The first tier of birth control are the most effective. So I put a crown here because they are the best. So tubal ligation is just getting your tubes tied. This is a birth control for women who are not interested in ever getting pregnant again. It is reversible, and I've had patients do that when their goals had changed, but it's definitely not an ideal birth control to have to reverse. So we only save tubal ligation for women who are done having children. Another option would be Nexplanon, which is a little implant. It's about the size of a matchstick, and they put it in between 2 little muscles in your arm, and you can actually run your finger over it and feel it. And it's typically done in an obstetrician or gynecologist's office. They put a little bit of numbing medication and then they implant it right under the skin. So it doesn't require you going into the OR or having a surgical procedure. And you can feel it, and they put it in between 2 muscles so that it stays there, so that it doesn't migrate in the body at all. It is a very, very effective birth control. So the way that we like to explain it is that if 10 women use Nexplanon, only 1 or less would get pregnant. It is a very, very, very low chance of getting pregnant. The next type is called an intrauterine device. So there are different types. There's a copper one that can last up to 10 years. And then there's some that are hormonally based that can last 3 to 5 years. So it depends on the type that you want to use and how long you want it to last for. Something that women often ask us is, if I get my IUD taken out, how long until I can get pregnant? And oftentimes women can start attempting right away after the IUD is removed. And normally women don't have any issues conceiving after the IUD is removed. That is also done in the clinic. Typically here's a picture of it here at the bottom. It's kind of a little T shape. It's very, very tiny. And it's done in a gynecologist's office, and they use a little device. They go through the vaginal canal, and then they insert it on the top of the uterus. So the uterus is kind of shaped like a dome in your lower abdomen, and it's connected to the vaginal canal. So as they go up, they implant it on the top of the uterus. And I have had women say that they have some cramping and abdominal pain, maybe a little bit of bleeding afterwards, but it is also one of the most effective birth controls we have at our fingertips. So if you don't want to have the tubal ligation, which is a surgical procedure and is permanent in most cases, we would highly recommend the Nexplanon or an IUD. Now, both of these are safe in women, regardless of your clotting history or regardless of your lupus activity. And that's because the IUDs act very locally. So they act in the uterus itself. We're not expecting systemic or body-wide absorption. And then the Nexplanon is just progesterone. It doesn't contain estrogen, which is the hormone we're mostly concerned about, either flaring your lupus or causing you to have blood clots. So these are 2 really great options for birth control. And they can be removed at any time. So if you get an IUD or you get the Nexplanon and 6 months later you want to get pregnant, they can take them both out in the clinic, and then you can start trying to get pregnant. All right, the next tier is going to be a whole hodgepodge of things. So I feel like most women know about birth control pills, and birth control pills are the second one listed here, and they contain estrogen, again, a risk for clotting. So if you're a woman whose lupus is very well controlled, you've talked with your rheumatologist, and you don't have a history of blood clots, and you also don't have any of those autoantibodies that put you at higher risk of having blood clots, you could consider a birth control pill with estrogen. But let's say that you want a pill, but your lupus is a little active, or you've had blood clots in the past. There's something called the mini pill, and that is just progesterone. And so that is safe for you to use despite any of the other factors. Now, I will say that the mini pill you have to take every day at the same time. And if you miss one dose, you're at risk of getting pregnant. It is very, very strict. And it's kind of unrealistic. I mean, a lot of us put alarms on our phones, but it's really hard to take a medicine at the same time every single day. So while this is an option, just know that there is a big risk of breakthrough pregnancies. And while the former tier of birth control was less than 1% of women got pregnant per year, this is higher at 6 to 9% of women will become pregnant in a 1-year span if they used these birth controls as they were intended. So they took the mini pill every single day at noon like they were supposed to. There's still a risk of getting pregnant of 6 to 9%. Now, there's other things like a vaginal ring that you insert into the vaginal canal. Now, as you see here, again, if you have low lupus activity, you can use it. But if you're high activity or you have history of clots, let's avoid it because it has estrogen in it. Something that's really important is the birth control patch has such a high amount of estrogen that we recommend all women with lupus avoid it. Regardless of how active you are or regardless of your clot history, there's so many other options. And the estrogen concentration was just so high that it made a lot of rheumatologists uncomfortable. So we recommend just avoiding that and using an alternative that is probably a lot safer for your situation. Depo-Provera is an injection that you can get. And as you see here, it doesn't matter how active your lupus is because estrogen is not in this. But if you have a history of clotting, we want you to avoid it. Also, if you have a history of weak bones, something called osteopenia or osteoporosis, which is certainly a risk factor in women who have been on prednisone or steroids for a long period of time, we want you to avoid Depo because it can actually worsen and weaken the bones over time. So choose an alternative that doesn't affect your bone health, but still gives you protection against unplanned pregnancies. Last thing is if you take a medicine called Cellcept or mycophenolate, it is an excellent medication for lupus, especially lupus that impacts the kidneys. It's one of our favorite drugs, but it interacts with oral birth control pills. So if you are on Cellcept or mycophenolate, please use an alternative birth control that's effective because if you take the pills with Cellcept, the pills become less effective and then you're more likely to get pregnant. And Cellcept is a teratogen, meaning that it's very, very, it can be deadly to the developing fetus, but it can also cause a lot of deformities as well. So it would just be a terrible situation for you to have an unplanned pregnancy and then the baby be exposed to the Cellcept. So just to avoid that as much as possible, we recommend an alternative birth control. All right, the least effective birth control is the lower tier. And what I would say about these forms of birth control is we like you to use them in combination with other birth control that I've already talked through. So if you have an intrauterine device or an IUD and you have a new sex partner and you're not sure of their STI or sexually transmitted infection history, use a condom because condoms are the only form of birth control that can actually protect you from STIs in addition to preventing pregnancy. But condom use alone is not very effective for preventing pregnancies. As you can see here, 10 to 25% of women who use these forms of birth control will have an unintended pregnancy over a 1-year period. So in addition to condom use, some women and men can use spermicide as well. Cervical caps and sponges are not used as often anymore, but they certainly are options. And then fertility awareness is when women track their ovulation or their periods on an app on their phone, and they avoid sex during periods of fertility. But that's about as effective as consistent condom use, still with 10 to 25% of women becoming pregnant at the end of a year. So use these in combination with the other forms, like maybe you use birth control pills and you use condoms. It's never going to be wrong to use multiple forms of birth control. Now, we wouldn't recommend multiple forms of like hormonal birth control, but from the different categories, like if you have, like I said, IUD and a condom, it's okay to use birth control from different tiers because it's going to only protect you more against an unplanned pregnancy. Okay, so this is kind of the phenomenon I was alluding to a little bit earlier. So I see women in clinic. We have an autoimmune pregnancy clinic, and we also do preconception counseling. So a woman will come to us and she has lupus and she says, I'm 25 and I don't want to get pregnant in the next year. And I'd love to start a birth control, but I've been trying to do this for a year and nobody really knows what to do with me. And what happens is women go to their primary care doctors and the primary care doctor says, oh my gosh, you have lupus. Well, I'm not going to do anything because I don't want to mess up your rheumatologist plans. I don't know if birth control interacts with your disease or it causes issues. So I'm just you can talk to your rheumatologist about it. So then you go to your rheumatologist and they go, oh gosh, I don't even know what the birth control options are. How about I send a referral to gynecology? You can talk with them about your options and then you guys can decide. And then the gynecologist does exactly what the primary care doctor does. And then nobody talks to each other and you're kind of just like caught in the middle. And honestly, we do research on this. A lot of women get pregnant in this time period because everybody is kind of not sure what to do, but nobody really takes control of the situation. And then there's an unplanned pregnancy, and that's not fair to the patient. So what we want to do is, and I give these talks to other physicians as well, especially at the VA. I go to primary care doctors and women's health clinics, and I give these talks in order to empower the physicians to take care of you guys because they get nervous that they're going to do something wrong and they're going to hurt you or you're going to have a bad outcome. So to avoid all of that, we can just become more educated so that patients get the birth control that they need. So this is what that handout is that I was talking to you about. Just take notes as I'm talking, things that are important to you. And then you can print that handout off and then go to your doctors and say, I've already talked to my rheumatologist. These are my birth control options, and I would like to have a Nexplanon implanted, or I would like to have an IUD. To us, that would be the best outcome of these talks because you can make the best decision for you. And you're not like sitting around waiting for doctors to decide who's going to take control. Okay, so what if you do everything right? You have you decide to use birth control pills and condoms as your two forms of birth control, and either the condom is dysfunctional or you forget to take your mini pill at noon one day and you're at higher risk of becoming pregnant. So this is what we call birth control failures. So one time I gave this talk and somebody asked, what does it mean when birth control fails? And it's something like that. Either you don't take the pill on time, the condom breaks, your IUD falls out, which does not happen very often. That would be considered a failure. And so in that case, we recommend Plan B, which is an emergency contraception. Now, you can use this within 3 days of unprotected sex. And it's very important for me to explain to everybody here what Plan B does. It actually prevents the combination of sperm and egg to create an embryo. So one time in clinic, I recommended emergency contraception to one of my patients, and she goes, oh, I can't do that. That's against my beliefs. And so I had to explain to her that it's not an abortion pill because that's very important to a lot of women. And I want to make sure that they understand the mechanism of the drug instead of just assuming that it's an abortion pill. So it is not an abortion pill. It just is a super form of birth control. It serves the same function as the birth control pill and the condom that you originally used that failed you in the first place. This is your Plan B. So you can buy it on Amazon. They can ship it same day. I did a search earlier today. It actually went down in price. Last year when I gave this talk, it was like $45. Now it's down to $35, which is great. So you can have it shipped to your house. You can actually go to a pharmacy and buy it over the counter. You don't need a prescription from your doctor. So I always recommend women have this with them in their medicine cabinet. Just buy a Plan B and then keep it in the back of your medicine cabinet because if you ever need it, it's there for you. We also recommend patients bring it on vacation with them. Just pack it in your suitcase just so that you have it. And it's a nice safety net in case anything happens. It is also safe for every single woman to use. So even if you've had blood clots in the past, even if your lupus is just raging and super active, you can take Plan B. So there's no restrictions for you when it comes to an emergency contraception. Now, we work very closely with our gynecology colleagues. So whenever we do preconception counseling or we're managing a pregnancy, we work very closely with either maternal fetal medicine, which is a high-risk obstetrician group, or we're just working with our local OBGYNs. And so they're always making the calls on, you know, when somebody delivers in pregnancy management. We're always working in connection with them because we're the autoimmune expert, but they're the pregnancy.
Hello. Oh, hey. Good.
Let me see. I don't know. Okay. All right. I was going to try to mute somebody. Okay. I think we're good now. So we're always co-managing these patients together, and acog.org/patients and bedsider.org are really, really great resources for more information about birth control and pregnancy. So again, so we're the autoimmune experts, they're the pregnancy experts. And so we never want to overstep our boundaries. We always want to be experts in our own field that then come together to manage a patient. So I would recommend you check out these resources as well. Okay. So now we're going to talk about women who want to become pregnant in the next year and what steps you should take. So step one is this the right time for me to become pregnant? And that's a really, really big question. It's a very, very personal question. And so the context that I'm talking about here is just in the context of your lupus. Obviously, you're going to be talking to your family and your partner. You're going to be having a lot of self-reflection and deciding, you know, is this the right time for me? And so when you come to see us in rheumatology clinic, our big question is, okay, so you want to get pregnant. We need to look at how active your lupus is, what type of we call it end organ damage, which means, have you ever had kidney involvement or other organ involvement where the organ doesn't function optimally? And therefore we have to make sure that we support that organ through the pregnancy. So for example, if you've had lupus that impacts your heart, we may go ahead and get an ultrasound of your heart. We may have a cardiologist follow you through the pregnancy. If it's affected your kidneys, then we might have nephrology be consulted, and we might measure the amount of protein in your urine. So it kind of just depends on how your lupus has manifested over the years. So we want to see how active you are, and that's through blood work. We look at inflammatory markers. We look at certain lupus antibodies, things like double-stranded DNA and complement levels. Those are blood markers that can tell us how active your lupus is. And then obviously we want to know how you're feeling. So are you having a lot of joint pain? Are you having a lot of rashes or ulcers or hair loss? All of those things together help us to understand how active your lupus is. Now, the next thing is, which medications are you taking? So let's say that your lupus is very well controlled and you're in a good place to start trying to get pregnant. We want to know what medicines you're on. So on the next few slides, there's going to be a list of medications called the GO medications and the STOP medications. GO medications mean that they are safe for pregnancy and breastfeeding. STOP medications mean that they are not safe for pregnancy or for breastfeeding. So we want to make sure that you're on the right medications, that your disease is well controlled before we start the attempt to become pregnant. And I'll tell you that your physicians love it when you come to us, and we have around 3 to 6 months in order to decide about getting all your medications in the right place, getting your disease under control, because that takes time. Because if we have to change your medications, your disease may flare in response to that. And so I want to make sure that I have you on a great medication regimen, your lupus is well controlled, and you're in a good spot to have the best pregnancy outcomes possible. All right, so I already talked about this a little bit, but minimal urine protein. Another thing is no flare requiring prednisone in the last 6 months. So if you're frequently flaring through your medications and you're needing prednisone constantly, that tells us that we need to get better control of your disease with a better medication regimen. And it's also important because we want to minimize the amount of prednisone during your pregnancy. We can certainly give it if we have to, but we like to avoid it because it increases the risk of high blood pressure in pregnancy, diabetes. It can also cause early delivery as well. So we want to minimize that as much as possible during the pregnancy itself. And then we're also checking these are the 3 autoantibodies that I've been referencing the whole time with their very long names. And then there's also the Rho or SSA antibody. Now this Rho is really important because it can cross the placenta and it can cause something called neonatal lupus, which is lupus in the developing baby. And this typically happens to about 10% of babies who will get a rash. That's typically how neonatal lupus presents itself. And the baby, as it clears out the mother's blood and produces its own, it will actually clear those autoantibodies, and then the neonatal lupus will go away. The rash will go away. But there is one side effect that we're very, very worried about. And when the Rho antibody crosses the placenta, it can actually cause issues with the heart of the baby. It can cause issues with how the baby's heart beats. So one thing that we do is we start Plaquenil or hydroxychloroquine in all women with lupus who get pregnant. We want everybody on Plaquenil, and especially in these women who have the Rho antibody, because it decreases the chances of heart issues in the baby to about 1 to 3%. It cuts it down very, very, very low. So the chances of your baby having either the rash from neonatal lupus or a heart issue is drastically reduced with starting Plaquenil, typically in the first trimester. But we normally, if you're trying to get pregnant, we have you on Plaquenil at the beginning. So this is a list of the GO medications. So these are all safe in pregnancy and in breastfeeding. So if you got pregnant and you're on medications only on this list, that's great. You can stay on them. We don't have to make any adjustments or any changes. But if you're on a medication from this stop list, and you're thinking about getting pregnant, then we're going to slowly wean you off of this and then start you on a medicine from the GO list. Now, let's say you have an unplanned pregnancy and you get pregnant while you're taking methotrexate or Cellcept. You stop the medication immediately. And a few of these medications have antidotes that I'll talk about a little bit later. You stop it immediately, you call your rheumatologist, and then we'll start you on a medicine on the GO list. And typically we talk to the high-risk obstetrician. You'll see them in clinic, and they'll do some extra anatomy scans on the baby just to make sure that there aren't any malformations or changes in the baby's development because of the accidental drug exposure. Now, another thing you'll notice here is that we love baby aspirin. So starting an aspirin during the first trimester is a preventative for preeclampsia. So preeclampsia typically happens in the third trimester. It can be deadly and it can progress to something called eclampsia, where women have seizures. Now, we want to prevent that as much as possible. So preeclampsia is high blood pressure, lots of protein in the urine, can cause some belly pain. So starting an aspirin has been shown to be a prophylactic against preeclampsia. And also at your visits with rheumatology and your obstetrician, we're always screening your blood pressure. We're always looking at your urine. We're checking your liver enzymes. So we're always monitoring for that constantly. And the only solution to preeclampsia is delivery. So no matter how far along in the pregnancy you are, we have to deliver the baby for your own safety. So we want to prevent preeclampsia as much as possible. And women with autoimmune diseases who have inflammation are higher risk to developing things like preeclampsia, especially women with lupus who have kidney involvement. So that's a very special population where we're constantly starting aspirin and closely monitoring for the signs of preeclampsia. And lastly, if you have any other additional medications outside of your immunosuppression, always talk to your obstetrician about every single medicine that you're taking, because they'll be able to tell you if it needs to be switched or changed, or the dose needs to be changed as well. Now, in rheumatology, we have so much research going on. There's always new drugs. So most recently, anifrolumab, rituximab has also become a medicine we use pretty consistently in lupus, especially for lung inflammation, maybe joint pains. But rituximab and Benlysta are two medicines that we just don't have a lot of information on in pregnancy. And when that's the case, most of the time we're going to stop those medications and then switch you to something that we do have better data on. But I'll tell you that we've become a lot more comfortable using rituximab in pregnancy. Dr. Close and I at Duke will dose it at different times during the pregnancy. So if somebody's trying to get pregnant, we may have them get rituximab, and then that rituximab lasts for 6 months. And they can have it during the pregnancy, and then maybe we'll give it to them again after they give birth. So there's like a 3-month period where we may have other medications that we're using, but we're becoming a lot more comfortable. And you'll notice that as a new medicine comes out over the next 10 to 20 years, pharmaceutical companies and researchers will do a lot of data collection, and then they'll be able to tell us what the risk of fetal malformation is, miscarriage, all those things. Because there's medicines like cyclophosphamide, which is a very, very strong medication that we use. It actually causes a lot of miscarriages. And so that's on the stop list right here, Cytoxan, that's on the stop list. So we know for certain medications that they are teratogenic or very, very bad for a developing baby, but some medicines we just don't know at this time. So what we recommend is if you get pregnant and you're taking one of these medicines, wait until your next dose, just call your rheumatologist and explain the situation. And then they can talk about whether you should continue or if we should switch medications, especially depending on whether or not you want to keep the pregnancy. So who should be involved during your pregnancy care? So you're probably going to have a big team of doctors. It's not a bad thing because we all have specific interests. So as the rheumatologist, I'm very, very focused on your lupus. And then the maternal fetal medicine doctor is very focused on your pregnancy. And then if you have a cardiologist or maybe a dermatologist or a kidney doctor, they're all very focused on their organ system. And so it's really nice to have a diverse group of doctors who can all talk together and work with each other in order to come up with the best plan for you, depending on which organs are involved in your lupus. As rheumatologists, I would recommend that we see you at least once a trimester. And that's in cases where your lupus is well controlled, everything is going great. If things are active or we're switching medications or you're flaring, we'll probably see you more frequently than that so we can continue to reassess and get things under control before they get out of control. Again, MFM or maternal fetal medicine, these are obstetricians who have extra training in high risk pregnancies. So they are better at anticipating potential complications and work a lot with women who have autoimmune diseases. They are really, really phenomenal. A lot of women will get referred to a maternal fetal medicine specialist at like a big university hospital, and then they'll keep their local obstetrician. And the local obstetrician will be guided by the maternal fetal medicine doctor from afar, which is really nice because then you can keep your local doctors. You can maybe sometimes even deliver at your local hospital, but you have the advice and the guidance of a high-risk obstetrician guiding your team through any complications that may arise. So other very specific health issues in women with lupus. So antiphospholipid syndrome are those 3 autoantibodies that cause clots. So everybody should take a baby aspirin if you have antiphospholipid syndrome, but honestly, we're recommending it in almost everybody with lupus because of that preeclampsia prophylaxis. If you have a history of a blood clot, most commonly women will get blood clots either in their legs, like a deep vein thrombosis or a DVT, or they'll have it in their lungs, like a pulmonary embolism. You can definitely get strokes other places or blood clots other places. But if you had a blood clot before, typically you'll be on a blood thinner, something like low molecular weight heparin or Lovenox. And this is a shot typically that you give yourself 1 to 2 times per day, and it thins the blood. This is important because in pregnancy, there's changes in the chemistry of the blood, and you actually become more likely to clot during pregnancy. And actually 6 weeks after you deliver is when you're also very high risk to have a blood clot. So that's why it's important that we give you blood thinners during the pregnancy if you've had a history of one, or if you have some of these autoantibodies, because pregnancy puts you at even higher risk of clotting. So typically you'll come in and we'll have our pharmacist train you on how to do the injection, and you'll do it at home by yourself. You can either have somebody at home help you with it, or you can do it yourself. You can actually inject into your belly. That was a question I had when I first started working with pregnant patients. But the needle is so tiny, it does not reach into your belly or into the placenta. So you can continue to inject into your belly or into your thighs daily during your pregnancy to prevent blood clots. Now, this Rho antibody or SSA is that antibody that crosses the placenta and can cause issues with the baby, either neonatal lupus or heart issues. So Plaquenil or hydroxychloroquine is a very, very safe medication in pregnancy. Normally, we have you take 2 tablets per day during pregnancy because that's the highest dose that's safest for you. And then we also, if you have this Rho antibody, you'll have ultrasounds of the baby's heart. So you'll go see a cardiologist who specializes in pediatrics, and they'll do an ultrasound of your baby's heart every 2 weeks, typically between the weeks 17 and 27 of the pregnancy. You'll go every couple of weeks, and they look at how the heart flutters and they make sure that the heart's beating appropriately. And if they do notice an issue with the heart, we have certain treatment options that we can offer you in order to try to prevent any further damage to the heart. Blood pressure is very important in pregnancy. So we check it every time we see you in clinic. Sometimes women will get home blood pressure cuffs so that we can continue to monitor. But ACE inhibitors, something like lisinopril, is not safe to use in pregnancy, or angiotensin receptor blockers. So that's something that your obstetrician would change you to a safe alternative to keep your blood pressure under control during pregnancy. And then last is pain, definitely not least. We typically will recommend things like Tylenol during pregnancy. So we try to avoid things like ibuprofen and Motrin because NSAIDs can affect certain valves of the baby's heart, typically 20 weeks or later into the pregnancy. So the FDA has a warning at 20 weeks and later not to use any NSAIDs at all. So we just try to avoid it as much as possible. And we rely very heavily on Tylenol. You can take up to 4 grams per day of Tylenol as long as your liver is healthy and you don't have any history of issues with it. So we try to maximize that as much as possible. And then sometimes women need low-dose prednisone in order to help their joints if they're having a lot of swelling or flares. Okay, breastfeeding. So the new trend in breastfeeding is that we say a happy baby is a fed baby. So if breastfeeding is not for you, if it's not something you're interested in, that is okay. We just like to say, as long as the baby is getting nutrition, it will be a happy baby. I've had a lot of women tell me that they have issues with latching or milk production, and they get really discouraged and they feel guilty and bad about that. And so we're really trying not to encourage that mentality at all. Being pregnant and giving birth is a life-changing event, and you are doing your best. And especially with lupus, you have other things you have to worry about in your own personal health, and you're not getting a lot of sleep, and I'm sure you don't feel well, or you don't feel at your best. And so we just tell people that if you have to supplement with formula or your baby is formula fed, that is okay. And that is a personal choice that you can make with your partner, with your family, or after talking to your doctors. Now, that being said, if you want to do breastfeeding, all those medicines on the go list that you were taking during pregnancy, just keep taking them through breastfeeding because they don't excrete enough into the breast milk in order to affect the baby. So there's a great website called lactmed.com, and it has all the medications that are available in the United States. And they actually do studies. They cite literature on how much is excreted into the breast milk and then absorbed by the baby. And so things like ibuprofen, you can take that while you're breastfeeding because it has the least amount excreted into the breast milk and it doesn't impact the baby at all. So that's wonderful. There's a few extra medicines you can take in breastfeeding that are not as safe in pregnancy. So after you get through the pregnancy phase and breastfeeding, we actually have a lot more options, which is good for you, especially if you're having joint pain or any issues. Again, it's recommended for the first 6 months, and then supplemented breastfeeding is recommended for a year or longer. But again, that's going to be in your specific situation. And as long as baby is getting nutrition, your doctors are going to be very happy. Okay, so what if you have an unplanned pregnancy? So if you want to continue the pregnancy, which is always the first question, you should ask yourself, and when you talk to your doctor should also be asking you, is this a pregnancy you want to continue? And if so, then we're going to make changes to your medication. So if you're so let's say you're on methotrexate and you accidentally get pregnant, we're going to stop the methotrexate right away. We're going to start you on something called high dose folic acid, which is kind of an antidote to methotrexate. And then we're going to switch you to a medicine that's safe in pregnancy. So that's what that conversation will look like. We'll change you over to safe medications, and then we'll talk about your disease activity and what changes we need to make to the strength of your medications, maybe get your disease under better control as well. So if you're on a yield medication, like I said before, just hold off on additional doses before talking to your and then talk to your rheumatologist before taking anything additional, just in case there's any issues about how safe it is in pregnancy. If you want to get pregnant, or if you're sexually active, start a prenatal vitamin. I tell this to all of my patients because if you have an unplanned pregnancy and you're already taking a prenatal, you have enough folic acid in order to help neural development in the baby, So it's just like a multivitamin with some extra stuff in it. It helps hair and nail growth as well. So it's not going to hurt you. And if you have an unplanned pregnancy or you're trying to get pregnant, you're already on it. It is safe to use in lupus. I'd highly recommend it for everybody. And then make an appointment with your rheumatologist and your gynecologist as soon as possible to discuss the pregnancy and what the next steps are. But your rheumatologist should be able to give you advice over the phone before they see you in clinic. So you say, hey, I'm on methotrexate and I'm pregnant. They should be able to tell you the next steps in order to prevent any further harm to the pregnancy. And if you have an accidental exposure, Mother to Baby is a phenomenal website and group of people who actually gather information on accidental exposures in pregnancy. So this is how we get a lot of data on certain medications like Benlysta. Women will be on Benlysta, they'll accidentally get pregnant, and then they'll enroll in Mother to Baby, and they'll monitor their pregnancy to see if the baby has any malformations or the pregnancy has any complications. So if you do have an exposure, they offer really great advice, but it's also a chance to be a part of a research project on a specific medication. Okay, now what about infertility? So lupus itself doesn't typically cause fertility issues. The problem that women will run into is their medications can hurt their fertility, or typically women who have lupus have to put off pregnancy for a while because they're either sick or their medications aren't compatible. So they may wait past 30 to have a baby. And even though that is not old, and pregnancy, it becomes advanced maternal age. I think it's 35 and older. And so it's just a little bit higher risk. And so it's not the lupus itself, but it's the environment that lupus creates for women. They have other health issues. So things like cyclophosphamide can impact your ovaries. And there are medications that you can take with the cyclophosphamide to protect your ovaries as well. But if you've had those medications before, or you have, advanced maternal age and you just cannot conceive, there's a lot of different options for artificial or assisted reproductive technology. Now, just like with birth control, in ART, your level of lupus activity matters. So if you have super active lupus, we would recommend holding off on ART. There's a lot of hormonal shots and changes that you have to make during ART. And we're afraid that with high lupus activity, that may worsen the lupus. You may be higher risk for clotting. So we'd like your disease to be well controlled, just like for pregnancy. We want you to be well controlled before you undergo any type of fertility procedures. Do not do fertility procedures while you're taking cyclophosphamide. So cyclophosphamide is basically suppressing the function of your ovaries. And then in ART, we're trying to promote the function of your ovaries. So they would just be working in different directions, and it likely would not be successful. And if it was, it would be very, very hard on the pregnancy. So if you're on cyclophosphamide, switch to something that's more compatible with pregnancy before you undergo ART. And again, if you have a history of antiphospholipid syndrome or certain autoantibodies that cause clots, your doctors may actually start you on a blood thinner like aspirin or Lovenox, which is the injectable one, before you start undergoing infertility therapy because of the hormonal treatment. So you'll have a fertility specialist, but you should also be talking to your rheumatologist about your plans for infertility treatment, just so that they can advise you on what medications you should be on before undergoing the procedure. All right, so now moving on to menopause. So women can have hot flashes and night sweats. And so a question that we get is, can I start hormone replacement therapy in order to mitigate some of the symptoms of my menopause? And normally, hormone replacement therapy is not standard. It's not like we give it to every single woman who's been through menopause and who's having some symptoms. Typically, the symptoms have to be pretty they have to affect your personal life pretty extensively. Like maybe it's preventing you from sleeping or functioning or going to work. That's when we're more likely to go ahead with hormone replacement therapy. But again, just like with fertility therapy and pregnancy and birth control, there's hormones involved. So if you have a history of blood clots or you're in a lupus flare, we would recommend avoiding hormone replacement therapy. But if you don't have any of those autoantibodies, your lupus is well controlled and your menopause is just controlling your life, then there's certainly a role for hormone replacement therapy for those patients. But just knowing the risks involved with it is very, very important. My last slide is on COVID vaccination. So last year when I gave this talk, it was a little bit more of a hot topic, but COVID vaccinations are safe in all patients with all autoimmune conditions. It has not been shown to cause a flare of an autoimmune disease, at least not in large quantities at all. We recommend that women who are pregnant or trying to get pregnant or who are on birth control, all of them should get a COVID vaccination. There's no data that COVID vaccinations cause fertility issues. There was a study where they tracked women's menstrual cycles on an app, and their menstrual cycle was 1 to 2 days late after the COVID vaccination, but then restarted normally after that. That delay in your period should not affect your fertility at all. So please don't be afraid of the vaccination because of pregnancy or because you're trying to get pregnant or because you're afraid it'll decrease your chances of getting pregnant. It's also safe in breastfeeding as well. So all of the major organizations, our colleagues in obstetrics and gynecology, and also the World Health Organization recommend COVID vaccinations. And women who are pregnant who get COVID actually are very much higher risk for worse outcomes. So especially in your case where you're taking medications that suppress your immune system, we highly recommend COVID vaccines. And we typically have been doing 2 of the original and then 2 boosters after that for 4 vaccines total. But now we're getting really far out from the original vaccines, and there's not a lot of data on if we should just continue to vaccinate every 6 months. So kind of at your local rheumatologist's recommendations and in your specific situation, but it is safe in pregnancy and breastfeeding. So there's no concern there from our position. And that's it. Okay.
Okay, wonderful. Thank you so much. Such good information for everyone. And we do have some questions. Some of these I think you may have answered just in your presentation, especially the first one of asking about how to prepare for a healthy pregnancy. So I think we got that one. And
Yeah.
we had someone that said, I just gave birth 11 months ago and my first child has a lupus warrior of 15 years. It's possible and amazing, and he's healthy and active. So it's very possible. Yes. Okay, so I think we answered this one too, but there was a question about treating with HRT. Can lupus cause premature menopause?
Oh, that's an interesting question. Now, you could get premature menopause and lupus if you had a medication like cyclophosphamide that was toxic to your ovaries. And you have what's called premature ovarian failure, which is where the ovaries are no longer producing hormones, and then you go through menopause. So you can have premature ovarian failure from lupus therapy, specifically cyclophosphamide. But if you haven't had that, then lupus itself should not cause premature ovarian failure or premature menopause.
Okay, good. Another question, which I think is good, is how trustworthy is a vasectomy?
Oh my gosh, that is a great question. So I personally think that we should use vasectomy a lot more often. I love it when my women come into clinic and I'm like, oh, what's your birth control plan? They go, my partner's going to get a vasectomy. And I was like, that is a good partner, because vasectomies are a lot less invasive than tubal ligations are. So they are just as effective as getting your tubes tied. So they would be in that top efficacy pool of birth controls. And I would highly, highly recommend them.
Yeah, somebody said, and they're reversible.
They are reversible, yeah.
Can protein be present in urine without CKD?
Yes, it certainly can. That's an excellent question. So protein is kind of like one of the first signals of inflammation of the kidneys. So sometimes women are like, so the kidneys don't have neurons. So it's not like you have pain in your kidneys like you would with an infection. You can be like, I feel great, my lupus is all controlled. And then we check your urine and there's a little bit of protein in it, just a tiny bit. And you can be spilling very small amounts of protein and have a little bit of inflammation, but not have chronic kidney disease or even not have acute kidney injury at all. When it becomes important is if it passes a certain threshold of maybe 1,000 milligrams a day. We typically would see some type of change in the function of the kidney correlating with how much protein you're spilling, but the two are quite independent. So sometimes we'll check people's blood and their kidney function just looks stellar and normal. And then we check their urine and we're like, oh gosh, they're spilling a lot of protein. And that will actually prompt us to biopsy the kidney. because we're going to see it in the urine before we see it in the blood work. So you can definitely spill protein before having any type of dysfunction of your kidneys. And sometimes women will spill like 300 milligrams. And I know these numbers don't mean much to you, but that's a very small amount of protein. So that's okay. As long as your protein level is not increasing and it's not very high. If it's below 500, we're typically not doing a whole lot in order to act on that. But you can certainly have protein without kidney dysfunction.
Okay. I don't see a lot of other questions. There just are some people who, just are saying, thank you so much. Someone just said, thank you for the presentation. It was very insightful. I'm feeling less nervous about planning for my pregnancy now. So that is very helpful. Are there any other questions? If anyone has them, you could type them in the chat. I think this is a good sign, I think, of a good presentation when there aren't a ton of questions because you answered a lot of them.
I love hearing about successful pregnancies, the woman who put that in the chat, because I do work with vasculitis in pregnancy. And a lot of women don't want to participate in research because they said, oh, I had such a normal pregnancy, I can't offer anything. And I said, you are the exact type of woman that we want in our research and we want out there talking, because you are an example of what men want when they have a pregnancy. Like, they want to see women who have had successful pregnancies, whose babies are healthy, who have achieved their personal goals. That's what they want to see. So you should tell your story to everybody, because it is so encouraging to women who often feel extremely isolated when you have a chronic condition and you want to get pregnant. And a lot of women will go to social media or they'll go onto websites or forums and they feel so isolated. And that's really unfair. And so the whole point of these talks is to make you are not alone. And the way that you're feeling about being nervous, that is completely appropriate and normal. Being nervous is okay. I just want to make sure that you have the support to move forward in your pregnancy with doctors who are going to give you the best information. And it's okay to be nervous. And just hopefully the forums are helpful. Some people will do Facebook groups or Instagram, or just do online forums. And some women do find them helpful in order to talk through certain issues. So you can talk to women who understand what you've been through. But thank you for sharing your pregnancy, and for also the woman who said she's less nervous, because that is the whole goal of these things. Is we want to make sure that you're happy and healthy and getting, your personal goals the way that you've had them planned the whole time.
Yeah, absolutely. And, we hear from a lot of people at the Lupus Foundation, a lot of women, especially young women. I think some of you know, we do a camp for girls who have lupus, and it is always a topic of conversation. Girls who are, first of all, nervous about taking birth control because they've heard that, if 90% of people who have lupus are women, then it must be fueled by estrogen. And if I take birth control with estrogen, then is it going to, make my lupus worse? We hear that, but so many of them are really nervous because they've maybe read some old information about lupus and pregnancy, or, they don't know where to turn to get accurate information. And so I think this is helpful. I was just going to say, you typed in the chat, lupuspregnancy.org. We encourage all of you to go there to get more information and the forms that you were talking about.